You're in the ER and your patient just got wheeled in by EMS, short of breath, tachycardic, and saying their chest feels tight. The monitor shows a heart rate of 132, their SpO2 is dropping despite oxygen administration, and something just feels off. The provider suspects a pulmonary embolism. As the orders start coming in, a D-dimer, CT chest angiogram, and the provider is discussing starting a heparin drip, giving thrombolytics, or even calling IR, how do you anticipate what's next and stay ahead? That's why in this video, we're going to break down everything you need to know about pulmonary embolisms in the ER, how they present, what makes them deadly, the workup, key treatments, and important nursing considerations. Then we're going to finish it up with a realistic scenario to make sure you feel confident and ready the next time this patient rolls through your doors. And as always, thank you for watching. So, what is a pulmonary embolism? It's an obstruction of a pulmonary artery, and there's different types of obstructions, including blood clots, air embolisms, fat embolisms, septic embolism, and amniotic fluid embolism. But for the purpose of this lesson, we will focus on just blood clots. So PEs are significant because blood is blocked from going to the lungs, causing a sort of a traffic jam. This prevents blood from reaching the alveoli and getting oxygenated. It also ultimately decreases the amount of blood that reaches the left ventricle, causing a decrease in cardiac output and eventually hypotension. The traffic jam also leads to pressure building up within the arteries, within the pulmonary arteries, and this pressure or traffic jam piles all the way back to the right side of the heart, which is why the right ventricle also goes through dilation and pore contraction, adding to further hypotension overall. A key thing that will dictate treatment is differentiating whether the patient is hemodynamically stable or unstable. For example, a massive saddle pulmonary embolism, where the blood clot is at the bifurcation of the pulmonary trunk, where it splits into the right and left pulmonary arteries, this blood clot can limit blood flow and cause severe hemodynamic instability, requiring aggressive management and treatment. So, what are the symptoms? Well, the most common are going to be shortness of breath, tachypnea, and tachycardia. Shortness of breath and tachypnea are as a result of the body realizing that you're having difficulty picking up oxygen. So the body tries to compensate by having you breathe faster to get more oxygen into the lungs. The tachycardia is as a result, as a response, because the body increases the heart rate with hopes of perfusing the lungs more in order to attempt to get more oxygen into the blood, as well as to help with any hypotension that may be occurring. Other symptoms can include chest pain with breathing, of course, hypoxia and hypotension when the pulmonary embolism is severe, as well as signs of malperfusion like being altered and dizzy and lightheaded. Now, let's go into a little bit into the causes. One big one for PEs are going to be DVTs, as these can break off and end up in the lungs. So, when assessing your patients with pulmonary embolisms, you should always go down to the legs and look for signs of a DVT, like unilateral swelling and pain. Then you should also ask your patients about activities that limit movement and blood flow, like long flights or long car rides, as blood will pull down in the legs, increasing the risk of DVTs. Because if the patient just had a long flight or a long car ride and one of the lower extremities got super swollen and painful, and then all of a sudden they became short of breath, then it's likely a DVT is present. And now they may also have a PE as well. Also, keep in mind hypercoagulable conditions like pregnancy, being on birth control, cancer, and or having a recent surgery. Now, let's talk about the workup. One thing that I do want to mention is that providers have to rule out other explanations for the patient's symptoms. So things may be ordered that aren't just for pulmonary embolisms, but to rule out other conditions as well. This applies pretty much to all the workups, as the provider has to be sort of a detective to figure out what's going on. As we discussed, the symptoms of a pulmonary embolism include shortness of breath and chest pain, but those symptoms can also arise from a heart attack, from pneumonia, and so forth. The list goes on and on. Again, that's why providers often order many different tests to rule out different conditions. So now let's talk about the workup of a pulmonary embolism. Let's first start off with the D-dimer. which when ordered will be on a blue top, the same ones that the coags are obtained like a PT, PTT, and INR. So a D dimer is a protein fragment that is a byproduct of a blood clot broken down somewhere in the system, in the body. So again, a D dimer is a protein fragment that is a byproduct of a blood clot being broken down somewhere in the body. So when it's ordered and it comes back high, it signals to the provider that further diagnostic testing needs to occur, like a CT pulmonary angiogram. If it comes back low, then it signals to the provider that a PE may not be a likely cause of the symptoms. So a D-dimer is not going to diagnose a PE, but it helps the team figure out if additional testing should be performed. Know that a D-dimer can also be elevated in conditions like high inflammation, like malignancy and severe infections. The next important test is going to be a CT pulmonary angiogram, where, as the name suggests, contrast will be used to light up the pulmonary vascular in order to look for a PE. So, what if the patient is allergic to contrast or has really bad kidney failure and they shouldn't receive contrast? An alternative test is a VQ scan or a ventilation perfusion scan, where a patient breathes in a substance that is then picked up on imaging, showing how well the air is moving within their lungs. Then it's inserted via a vein and seen if perfusion is also adequate. And as a result, they can also see if there is a mismatch between the ventilation and the perfusion. But typically, the CT is going to be the go to unless there are contraindications present. Next, an ECG will almost definitely be ordered. The most common finding on an ECG will be sinus tachycardia. So remember that. But there are also going to be fancy findings that are not as common but can still be present, like a right bundle branch block or evidence of right heart strain as shown by T wave inversions in leads V1 through V4 and a prominent S wave in lead 1 and a prominent Q wave in lead 3 and inverted T wave in lead 3. But just remember for now that the most important finding on an ECG will most likely be sinus tachycardia. There's also these other fancy findings, but don't worry too much about those, just sinus tachycardia. Other tests include a bedside echocardiogram where the provider will likely see right ventricular dilation and strain. A chest x-ray is typically normal for a PE, but there is fancy stuff that sometimes shows up. But remember, the chest x-ray is also looking for things to roll out like pneumonia or even a pneumo. Then to cover all of our bases, a CBC, a CMP, and a troponin will likely also most be ordered. Now, for the treatment of a pulmonary embolism, first, always start with the ABCs. If you haven't already, check out my video on the ABCs for a deeper dive. Now, if your patient is hypoxic and hypotensive and may require intubation, you need to be extra cautious. These patients are at a high risk of crashing during the intubation due to several factors. Sedation meds stop them from breathing. Bagging is paused during the intubation, and this can worsen acidosis. And the meds and the positive pressure ventilation can drop the blood pressure even more, reducing the preload and increasing pulmonary vascular resistance. So again, when these patients are hypoxic, hypotensive, they're altered, and they're requiring intubation, you need to be extra cautious because all the things that we're doing for the intubation are going to make everything worse. The acidosis will get worse, the hypoxia will get worse, and we're even going to decrease the preload and decreasing further causing further hypotension. So what can we do in this situation? We're going to ensure proper pre-oxygenation. We're going to let the most experienced provider intubate so that it doesn't take long. And we're going to have vasopressors ready, including push dose pressors just in case we need them. And a small fluid bolus may also help depending on the patient's condition. Now, for the definitive treatment on pulmonary embolisms, it depends if the patient's stable or not stable. If the patient is stable, we typically start IV heparin to prevent the blood clot from growing. IV heparin, it's not going to dissolve the blood clot, but it gives the body time to break it down. If the patient is very stable, then subcutaneous Lovenox may also be used instead. Now, if the patient is super unstable, they're hypotensive, they're super hypoxic, they're crashing, and they perhaps have a large pulmonary embolism, like a large saddle pulmonary embolism, providers may choose to administer thrombolytics like TPA or TNK to actively break the clot down. On top of this, the patient may also go for a thrombectomy to remove the clot in the lungs. This again is going to be done in IR. So let's take a deeper look at the main treatment options: the heparin, the thrombolytics, and the thrombectomy. The heparin infusion, which is going to be done for most patients who are hemodynamically stable, because again, it doesn't dissolve the clot, but it prevents it from getting larger and from new clots from forming, and it buys the body's own fibrinolytic system to break the clot down naturally. Nursing considerations for this are that you need to follow your own facility's heparin infusion protocol, which will look something like checking a baseline CBC for a baseline hemoglobin to make sure there's no undetected bleeding. We're also going to check the platelets to make sure the patient is not thrombocytopenic. We're also going to check the coagulation studies like a PTT. We need a baseline before starting the drip because we're going to monitor the PTT every 6 hours. We're also going to check the INR. It's less relevant for the heparin itself, but useful for overall bleeding risk if the patient is perhaps on something else. And the providers may also, or your facility may also have a stool guaiac test that's necessary. This is essentially just looking for any occult GI bleeding, especially in these older or high risk patients. Now, when they're initiating the drip, it's going to be weight based most likely, and it's going to include a bolus dose and then a continuous drip. The drip rate is adjusted again based on the PTT, and it's going to be checked every 6 hours until until it's going to be at a satisfactory rate, the PTT level. But again, it's usually checked every 6 hours after you start it, right? And then again, like we said, for ongoing monitoring every 6 hours until therapeutic. And you're going to be monitoring for bleeding, like checking the gums, IV sites, the urine, the stool. And you're going to assess neural status regularly because we're monitoring for any intracranial bleeding. And you're also watching for heparin induced thrombocytopenia, which is going to be just a drop in the platelet count. And if this happens, you need to stop the heparin and notify the provider immediately if you suspect it. A pro tip for this is that before you start the heparin infusion, you need to have a good second working IV line, because one IV is going to be for the heparin drip, the other is going to be for anything else that may come up. Now, for thrombolytics, these are going to be used when the patient is super unstable and crashing, and in cases of a massive pulmonary embolism. These are going to be, again, clot busting drugs that are rapidly breaking down the pulmonary embolism. Again, we use TPA or TNK. You have to just know whatever your facility uses. If it's TPA, it's a small bolus followed by a drip most of the time. And if it's TNK, it's a one-time push. Again, know what your facility does and look through your protocol. The main things with thrombolytics is a high bleeding risk, especially intracranial hemorrhage. So if it is given, make sure you monitor the patient for their neural exam closely. Also watch the IV sites, the gums. You're going to avoid unnecessary sticks or Foley insertions afterwards. And before even giving it, you're going to make sure that there's no absolute contraindications for receiving thrombolytics. Now, for thrombectomy, if the patient cannot receive thrombolytics, or if the medical therapy is not working, like the thrombolytics or the heparin dip, the patient may go to IR for thrombectomy, where they're going to remove it via IR procedure. Now, to recap, if it's a stable pulmonary embolism, start with the heparin. If it's unstable or a massive pulmonary embolism, you think thrombolytics. And if those fail or the patient just needs more, they're going to go to IR for a thrombectomy. Understanding when and why each treatment is used will help you advocate for your patient and prepare for what comes next in their care. And by the way, if you're finding this helpful and want to save time and energy with mastering the chaos of the ER, check out our book and course. They're packed with everything you need, including foundational material, practice tests, and tips to help you become a confident and competent ER nurse. Links are below in the description and pinned comment. So let's go into the scenario. You're in the ER and your patient just got wheeled in by EMS. They're short of breath, they're tachycardic, and they're saying that their chest feels tight. The monitor shows a heart rate of 132. Their SpO2 is dropping despite oxygen, and something just feels off. So one of the first things you're going to do for this patient is get them on the monitor, right? The heart rate is 132. SpO2 is 93% on a non-rebreather. The BP is 135/98. Respiratory rate is 29, and their temp is 98.1 Fahrenheit. You and the team are going to simultaneously go down the ABCs. The airway is open. For breathing, the lung sounds are diminished bilaterally at the bases. The patient was hypoxic, but now they're on the non-rebreather. And for circulation, the patient is tachy, but the BP is okay for now. So what would you do next? Pause so you can think about it. At this point, make sure that you're placing a good IV in the AC because you're anticipating CT imaging with contrast while simultaneously drawing labs. What are the labs that you anticipate for this patient? Like we said, a CBC, chemistry, coax, and even a VBG or ABG that we typically get for all of these respiratory like patients. What else are you anticipating? Of course, the CT, a chest x ray, and an ECG as well. Remember, although the provider highly suspects a PE, they still keep a broad differential, meaning they are still looking to rule out all other deadly things like a STEMI, pneumothorax, severe pulmonary edema, severe congestive heart failure, and so forth. So, what about oxygen wise? Are they going to stay on the non rebreather? Think about that. Are you going to keep him on the non rebreather at this moment in time when they got there? I would keep them on the on the non-rebreather for the time being. This way, you can go to CT with it on. If you place the patient on high flow nasal cannula or something else, you still have to take them off to go to CT either way. So until they're crashing, I'd keep them on it for the time being, unless of course RT or the provider choose that it's wise to go the high flow right at this time. Now, if CT confirms the PE and the patient is getting more hypoxic, then is it gonna be more important to treat the cause, the PE, or to keep escalating the oxygen? The most important thing at this point, if the patient is getting more hypoxic and the CT confirmed the PE, is going to be to treat the cause, which is going to be the pulmonary embolism, while of course keeping a close eye on the patient and their vital signs and their SpO2 and on how hard they're breathing, and then further escalating if needed. But to address the issue, to address how they're feeling, it's going to be important to treat and address the pulmonary embolism. Now, the PE was confirmed and it's a large pulmonary embolism. The patient is becoming more hypoxic, hypotensive, and tachycardic, and any activity worsens it. What do you think the providers would decide to do at this point? They, of course, may go down the route of thrombolytics to break the blood clot down immediately since the patient is unstable. On the other hand, if it's a smaller pulmonary embolism and the patient is managing okay on oxygen and there's no obvious signs of heart strain and they're doing okay, they're most likely going to order a heparin drip so that they give the body enough time to break it down. Now, it all depends on the patient's presentation and how they are responding to treatment. This is why the primary RN is so important. You're prioritizing getting them the CT to the CT to get the results fast. You're keeping an eye on their overall respiratory status, and you're promptly communicating so if care needs to be more aggressive, it gets done. Now, let's go into specific nursing tips. So, a key diagnostic test is going to be the CT pulmonary angiogram. But what if you feel like your patient can't tolerate laying down or being flat? One super thing you can do is place the patient flat while still in the gurney in your room just for a few seconds and gauge whether they're going to be able to handle it. Essentially, if the patient starts immediately having a rough time and becoming unstable, then they may not be able to tolerate being flat for CT. And you must communicate this with the team, with the provider, so that you can come up with the plan for what we're going to do. If you're anticipating going to CT based on your patient presentation, you must know to place an IV in the upper forearm or AC, ideally an 18 gauge, but CT should also take a 20 gauge. If your patient is super sick, anticipate needing multiple IVs for different things. So have at least two good working IVs. It's also super helpful having an IV in the forearm so that you don't have to worry about the bending. Also, if the patient is a woman of childbearing age, and you must obtain a negative pregnancy test before going to CT. And then again, I made a video on nursing related tips related to thrombolytics, but remember to limit invasive procedures after and to closely monitor your patient for bleeding complications, just like a head bleed. If your patient is on the heparin drip, know that you're going to be repeating the PTT every 6 hours, titrating to a specific goal set by the provider. So please review your own facility's heparin drip protocol. If your patient gets intubated, be prepared for a crash during the intubation and immediately afterwards. Learn what questions to ask, including questions about recent flights or long car rides, or if one of the lower extremities got swollen and started hurting. And if chest pain, and also ask if chest pain is present and if it worsens with deep breathing. Now, for nursing specific tips going forward, you must be mindful of just ongoing monitoring after the treatment gets started. Even after treatment has started, whether it's heparin, thrombolytics, or even a thrombectomy, although they go to IR and go to the ICU afterwards, your job is going to be far from over after getting the intervention started, because patients can always deteriorate quickly and you must be able to recognize and act. So stay vigilant with your ongoing assessments. How's their work of breathing? Is the patient getting worse? They're using accessory muscles more? Are they tiring out? Are you seeing a worsening respiratory effort? If you do, that's going to be the first sign that everything is just going downhill, right? How is your SpO2? Keep a close eye on it. Are you having to go up and up? And if you do, you must be communicating that early on. How is their mentation? Because changes in mentation, in alertness, or confusion are going to be some of the first sign that oxygenation or perfusion are worsening. And again, keep an overall eye on the vital signs. Keep a close eye on the BP, on the heart rate, on the respiratory rate. A sudden drop in the blood pressure or a spike in the heart rate may indicate worsening obstruction or strain to the heart. And if you're noticing any decline, act early, notify the provider immediately, consider repeating the imaging or getting an ABG, and escalate oxygen delivery and prepare for intubation if necessary. Remember, anything can happen at any time, so you have to be proactive by staying ready, monitoring for worsening changes, and communicating promptly with the team. And overall, no one expects you to know everything right away when it comes to the working in the ER, but they do expect you to care enough about so that you have to go and learn. Take the time to study, to review, to look things up, get curious, ask questions, watch how experienced nurses do things and learn from them. Don't just memorize, but understand the why behind what you're doing. Because when that critical patient comes through your doors and time is precious, you're going to want to at least recognize what's happening and know what to do next. Remember, the more you know, the safer you are. Every shift is an opportunity to grow. So go the extra mile, look things up after your shift, review the basics again and again, and that knowledge becomes confidence, and that combined with experience is what's going to help you become a good ER nurse. And of course, check out our other videos to keep learning. And as always, teamwork makes the dream work. And here at Emergency Chaos, we are proactive, not reactive.